Yeah, I think with all of the anti-amyloid therapies, there's this question. Obviously, one is it good enough? They're just because something's statistically significant and meets its primary outcome doesn't necessarily translate into clinically meaningful improvement. And so there are some debates on whether or not lecanemab was able to produce a benefit that's actually clinically meaningful, which at the end of the day is really what we care about and what our patients care about. So we're waiting to kind of understand that better. That's on the efficacy side. On the other side is adverse events. And we've had enough of these anti-amyloid trials to see that the incidence of amyloid-related imaging abnormalities, the so-called ARIA, is a significant concern. This comes in two flavors. There's an ARIA-e, or the edema subtype, and then there's an ARIA-H, the hemorrhagic subtype. Fortunately, when this does occur, it tends to be asymptomatic. However, it's not always asymptomatic, and that's when we get really worried. And so I think, weighing the potential benefits of these therapies versus these adverse effects, such as ARIA, also infusion-related reactions were pretty common in the Clarity-AD trial. About 26% of patients had that. So these are all things that we have to weigh against each other as we're making decisions moving forward. And also considering that we're talking about administering a treatment to patients with mild cognitive impairment or mild dementia. And so we have to, put it into the overall context of the patient population we're dealing with here. We're always interested to understand differences with respect to sex, male, female, as well as racial differences as well. We know that there are some factors that play more strongly or more weakly in, say, African Americans versus Caucasians. So there are a lot of factors that we still have unanswered questions about, and these are questions we're going to have to get answers as we begin to move the field forward more.